welcome back to my channel. And today we are going to continue our sbas, and these sbas, they belongs to the genetic chapter, and this video is a continuation of a series of goal 5000 sbas before July 2023. So let's start with the question number one. The question number one is, what type of the inheritance pattern does the red green color blindness they follow? So the red green color blindness is the X-linked recessive. So X-linked recessive will be the answer. Red green color blindness, they follows an X-linked recessive. Let's continue with the question number two. Which of the following condition is caused by the chromosome microdeletion? Chromosome microdeletion. So the Edwards syndrome, the Down syndrome, and the Patau syndrome, they all are the trisomies, and Noonan syndrome is autosomal dominant. It's the cryoget, which is because of the chromosome microdeletion. Question number three, what is inheritance of the sickle cell disease? The inheritance of the sickle cell disease is the single cell autosomal recessive. Question number four, which of the following conditions they follow an autosomal recessive inheritance pattern? So let's see. Number one is adult polycystic kidney disease. It has a varied inheritance pattern. Then infantile polycystic kidney disease. Yes, this is the question number. Option B is the correct because it is an autosomal recessive inheritance. And what about the MEN Reed syndrome and vitamin D resistant rickets? They does not belong to this category. So question number five, a woman with a strong family history of the breast cancer, they has genetic testing. As she is worried, she may have the mutated BRCA gene. Fortunately test for, and this is the negative, but the patient, they wants to know if she is a risk of the breast cancer. What would you advise her lifetime risk of the breast cancer is? As the BRCA genes, they are negative, so the patient is belongs to the general population, and among the general population, it is the 12% risk of developing the breast cancer during their lifetime. By the age 70, if the BRCA1 and with the BRCA1 it is 55 to 65%, and with the BRCA2 it is 45%, and lifetime risk for the BRCA1 is 60 to 90%, and BRCA2 is 45 to 85%. In the general population, the 1.3% of the women, they will develop the ovarian cancer during their lifetime, and the risk of the developing the ovarian cancer by age 70 with the BRCA1 is 40%, and BRCA2 is 15%. All of the following are the autosomal recessive except. So let's see one by one. Yes, cystic fibrosis is autosomal recessive. Sickle cell is again the autosomal recessive. Osteogenesis imperfecta, no, it is autosomal dominant. Wilson disease is autosomal recessive, and PKU is again the autosomal recessive. A woman, they has undergone the genetic testing, and due to her family history with the BRCA1 gene, what would you advise her lifetime risk of the developing the breast cancer? Okay, what happened here is that the family history is positive, and in the general population, we have seen that there the 12% of the women, they have the chances of developing the breast cancer in the lifetime. But the risk of the developing the breast cancer by the age of 70, it with the BRCA1, but the BRCA1 gene is 55 to 65%, and with the BRCA2 gene, it is 45%. So if the patient has the BRCA1 gene, so the near option is 70%. So we'll choose the 70%. What happened that in the ovarian? What about the ovarian cancer? This was regarding the breast cancer. What is for the ovarian cancer? Okay, what happened that in the general population, 1.3% of the females are at risk of developing the ovarian cancer in their lifetime. With the BRCA1 gene, the chances increases to 39%, and with the BRCA2 genes, it is the 15%. Next question. A 40 years old woman who is 13 weeks pregnant is found to have the high risk of the Down syndrome, following the combined screening test. What is the most appropriate further test to see if the fetus is affected? So as she's at 13 weeks, so let's see some important things that what happened. That first comes the imaging or the non-invasive test. Here the knuckle thickness imaging is a part of the combined test and has been done. And as in our case of the in our case, then what is the next thing? It is a quadruple test. It is another screening test, and but here the quadruple test we have not been done. So next thing, the amniocentesis. So what is the amniocentesis? That the amniocentesis before 14 weeks of the gestation, they have the higher risk of the fetal loss and the increased incidence of the fetal talpes and respiratory morbidity compared with the other procedures. And though what does RCOG says? This says that if you want the amniocentesis to be done, do it after the 15 weeks of the gestation. So our patient is at 13 week of the gestation. So next is the chronic villus sampling. The chorionic villus sampling, they offer the rapid test and is suitable for the karyotyping, genotype analysis for the chromosome abnormalities such as the Downs, and this is the most suitable option because um, as waiting a few weeks and performing the amniocentesis is a legitimate option but would delay the diagnosis and ability to make decision for the termination of the pregnancy is again going to be delayed. So amniocentesis would be preferred method after the 15 weeks of the gestation. So before 15 weeks of the gestation, here the chorionic villus sampling is the answer. Okay, next question regarding the Turner syndrome, which of the following statement is true? So state number one, completing the monosomy. So Turners, they may be complete monosomy of a sex chromosome where the karyotype, the termed the 45X, or shows a mosaic pattern with the varied patterns, penetrations of the cell types with the single X chromosome. And complete monosomy, it accounts about the 50% of the cases. And so here the option is wrong because it is about the 50% of the cases. Next is that the Turner syndrome is a common in utero, affecting 1 to 2% of all the conceptors. However, the 99% of these will miscarry and only 1% will survive to the term. Turner's occurs about 1 in 20,000 live births, not the live female births, but the live births. So this option is again not going to work here. And then option C is only 1% of affected females, they will survive to the term. Yes, that is true. And next is that the short stature dysmorphism, including the short fingers, the pectus excavatum, and web necks, they are the features. And as are the cardiac abnormalities, coarctation of aorta, bicuspid aortic valve, and the aortic aneurysms, and the urogenital abnormalities, horseshoe kidneys, and the double collecting system, and more. And the behavioral problems, they are present in the, they can be present with the Turner syndrome. Next question, a 34-week-old woman is admitting to the labor with accident emergency. She has not had any contact with the health services during her antenatal period, and emergency C-section is performed due to the signs of the fetal distress. A small fetus is born and is noted to have the cleft palate, cleft lip and the palate, and the prominent occiput, and the low set ears, and the omphalocele, and the clenched hands with overriding fingers. And the baby is transferred to the SCBU due to the apneic episode. What is the most likely diagnosis? Yes, it is the trisomy A18. How? Because the features which are described here, they are seen in the Ptau and 18, but many of the features they are seen in the cryogenic as well. The key here as to which is the most likely is the incidence rates is that Edward syndrome is the live birth is about 1 in 5,000 live births, and Ptau is 1 in 15,000, and cryogenic 1 in 50,000 live births. So option trisomy 18 will be the correct option. Okay, the next question, a 31-year-old female, they has the blood taken at the 12th week of the gestation, which shows the elevated AFPs, alpha fetoproteins, and the normal pregnancy associated proteins normal, and the unconjugated estriol, it is again the normal. What is the result results. So here the only the AFPs are raised, and the proteins and the unconjugated esterols, they are normal. So the most likely option here will be the spina bifida, because we know it that the AFP is highly raised in the spina bifida. And let's see some explanation here. So what about the serum markers? And it is a PAP. One is a PAP, which is pregnancy associated plasma protein. And in the Down syndrome, in Edwards syndrome, what will be the difference? Because the most common is the Down syndrome, and then there comes the Edwards syndrome. So in the PAP-A, they are reduced in both the syndromes, and alpha fetoproteins are again reduced in both the syndromes. And however, they are raised in the neural tube defects such as the spina bifida and the multiple pregnancy. What about the unconjugated esterols? They are again reduced, and in both of the cases inhibin A is elevated in Down, whereas it is decreased in the Edwards, and beta HCG is elevated in Down and reduced in the Edwards. Now what about the trisomies? So number one, which is the most common trisomy, it is a trisomy number 21, which is the Down syndrome, and it is the most common chromosomal abnormality in the humans, and it occurs about 1 in 1,000 births. And basic screening by the knuckle thickness and the PAP and beta HCG and the blood markers, and from 14 plus 2 to 20 weeks gestation, quadruple test they can be done, and the screening test they determines the risk and the age decisions for the amnio and the CVS. Next is the Edwards syndrome, and it is about 1 in 6,000 live births, and 90% plus detected on the 18 to 20 week ultrasonography of the fetus anomaly scan, and has a poor prognosis, and median lifespan like 5 to 15 days. And third is the Patau, which is the trisomy 13, and it has a similar features of the to the Edwards syndrome, but it is less common than the Edwards syndrome. So which of the following is the leading cause of the Down syndrome? We know that it is the non-disjunction of the maternal gamete which lead to the Down syndrome, because non-disjunction, they account for approximately 95% of the cases, and 88%, and among it is the 88% is due to the non-disjunction of the maternal gamete, and 8% is the paternal gamete. And mitotic non-disjunction, they after conception lead to the mosaicism, and translocation Down syndrome, they accounts for the 4.5% of the Down syndrome. So question number 13, if both parents they have the beta thalassemia minor, what is the chances of their female offspring of having the beta thalassemia minor? So if the both parents they have the beta thalassemia minor. So minor means the both parents they are the carriers. So if this is a gene or healthy gene, and this is the abnormal gene of one parent, this is a healthy gene, and this is the abnormal gene of the other parent. So now let's do its crossing. This will become A, and this will become A, and again this will become A, and this will become this will become AA, and this will become AA. So according to this diagram, what is this? That what happened that? So one baby will be healthy, two baby are going to be the carriers, and the last baby will going to be the affected. So what is having? They have asked what are the chances of their female offsprings having the beta thalassemia minor. So again, they are asking that how many chances are there to have the babies with the carriers. So this is 50% will be the answer. Okay, I hope you understand this. If you don't, let me know. I'll do crossing in front of you again and again until you understand it. So next question, a couple they presents to a fertility fertility clinic after failing to conceive despite trying for the 2.5 years, and the semen analysis they show the azoospermia, and you perform a full examination of a male partner which reveals that the height is 192 centimeter and BMI is 20, and the small testes and the scanty facial hairs. You decided to organize the karyotyping. What is the result most likely? So here, if you see the features that that mm, if you see the features, so let's see that if it is a 46xy, and if the 46xx, so 46xy is a healthy male and 46xx is a healthy female. Next, the 46, uh, the 47 triple X, the 47 triple X or triple X syndrome, they would be seen in the females but not in the males. Then 47X double Y. The 47X double Y karyotypes affects about 1 in 1,000 men. 1 in 1,000 thousand men, but they have normal phenotypes. And here they are the different phenotypes, like they have small testes and the scant facial hairs. So the left is the 47 double XY. So 47 double XY, it is seen in the men of the Klippanters. And in the examination, if you ask about the karyotypes associated with the azoospermia and infertility, it is highly that they are asking about the Klinefelter syndrome. And other chromosomal abnormalities they lead to the azoospermia will be the cystic fibrosis and microdeletion of the Y chromosomes. So let's move to next question. Adult polycystic kidney disease, they typically follow which pattern of the inheritance? We know that adult polycystic kidney disease, they follows the pattern of autosomal dominant, and as the polycystic kidney disease, it can follow both patterns, dominant and recessive. But what is the difference? That adult they follow the adult they follow the autosomal dominant, and infantile they follow the recessive. Next question: what are the results suggestive of? So let's see the results. Here are the question. Okay, here they haven't given us the options and results. So let's see the next question. A 33-year-old female has a blood test taken at 13 weeks of the gestation, which shows the elevated AFP or alpha-fetoprotein. Which of the following condition is not associated with the raised alpha-fetoproteins? So that the multiple gestation, yes, they do follow the pattern of raised AFP, and then carefully, yes, again there are the raised omphalocele, yes, again there are the raised AFPs, gastrochesis, yes, they are again the raised AFPs, and D is the uh, D is the Edward syndrome. No, Edward syndrome that doesn't have the raised AFPs, because in neural tube defects, for example, the spina bifida and gastric multiple pregnancy, or osteophageal and the abdominal defects, they have raised AFPs. But what happened in the Edward and Down syndrome? They have decreased AFPs. Okay. Now, next question: you are following up an infertility clinic and note the male partner karyotype and has come back as a 47XYY. What phenotype would you accept to see in the in with the 47XYY? Which of the following condition is not okay? Again, this is the options are wrong over here. Let's see the what phenotype would you expect to see in the male with the 47 XYY. So the 47XYY, they have, we have discussed this previously, that they have the normal phenotypes, and which normally results in normal phenotypes. Next question: what is the mode of the inheritance of the beta thalassemia? So the beta thalassemia is autosomal recessive, we know that. And you see a patient in the infertility clinic, who you suspect has a Klinefelter. What is the likely karyotype? The Klinefelter, they have the 47 double XY. So the double XY, option C is the correct. Klinefelter is either denoted as double XY or 47 double XY, and of the sex chromosome trisomies, it is usually the only that produces a significantly abnormal phenotypes. Next question: a woman they has undergone the genetic testing due to her family history and has the BRCA1 gene. What would you advise of the lifetime risk of the ovarian cancer? We have discussed previously that it is above the 40%, and we know that in the general population, the risk of developing of of breast cancer is about 12%, and ovarian cancer it is about 1.3%. With the BRCA1 gene, the risk of the developing breast cancer by the age of the 70 is about 55 to 65%, and the ovarian cancer it is about the 40% with the BRCA1. And with the BRCA2, what happened that with the BRCA2 they have the 45% chances of developing the breast cancer and 15% chances of developing the ovarian cancer. So next question, a woman they has undergone the genetic testing due to her family history with the BRCA2 gene, and what would you advise her the lifetime ovarian risk? So it is the 15% we just discussed here above. Okay, a 16-year-old girl they has been referred to the clinic as she has amenorrhea, and she reports never having the periods, and her mother and the two sisters they menopause at the age of 12, and on examination you know the patient is 152 centimeter tall and the BMI is 29, and secondary sexual characteristics are not developed and her FSH level is elevated, and you organize a karyotype and are found as a result is abnormal. What you are going to show the result? So here it is 45x, because all the features it describes the Turner syndrome. As the Turner syndrome there is a loss of the X chromosome, so the patient only has a 45 instead of the 46 chromosomes, and the karyotype they can either be written 45x or the 45x not, and it is relatively common, affecting the 1 in 2500 females and at birth, and that is but they have good postnatal prognosis. 99% of the Turner syndrome's conception will result in the spontaneous absorption of the stillbirth. And 47 triple X they describe an extra X, and the triple X syndrome these patients usually exhibit no clinical signs, and though there is an association with the tall strictures and the microcephaly. And 47 double XY is a male phenotype seen in the Klinefelter, and 46 double X is the normal female karyotype, and 46X not they does 46X they does not exist. Next question is a beta and delta thalassemia. They are associated with abnormalities to which chromosome? So these are the chromosome number 11. Hemoglobin is made up of the 4 globulin protein chains, and adult hemoglobin is made up of the 2 alpha and 2 beta chains. 2 alpha and 2 beta chains, and 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 it accounts for 97% of the total hemoglobin in the normal adult, and HbA2 is a normal variant of the hemoglobin, and this consists of the 2 alpha and 2 delta chains and made up of the 1.5 to 3% of the total hemoglobin. Fetal hemoglobin is the main hemoglobin type in the fetus and persists after the birth for around 6 months, and fetal hemoglobin is composed of the 2 alpha and 2 gamma subunits, and alpha globulin chain is coded by the genes on the chromosome number 16, and alpha thalassemia they are therefore associated with the chromosome 16 defect. The beta and the delta globulin chains they are coded by the genes on the chromosome number 11, and beta and delta and thalassemia they are therefore associated with the chromosome number 11 defects. So next question, beta and delta thalassemia associated with abnormality to which chromosomes? Yes, we have just discussed that it is associated with the chromosome number 11. Next question, which of the following shows the correct gestation window for using the combined test for the chromosomal screening? For the chromosomal screening, we use the window is 11 plus 2 weeks to 14 plus 1 days of the gestation, and there are the number of the screening tests that can be used for the Down syndrome screening. They involve the ultrasound and the serum markers test, and some of the available test regimes they are the triple test, which is the AFP, HCG, and the estriol, and quadruple test AFP, HCG, inhibin A, and estriol, and combined test is the PAP, A, and HCG, and ultrasound. The combined test involves a single appointment where the rest of the blood serum markers they are taken in addition to the ultrasound assessment, and ultrasound measurements for a fetal length of the crown lump length to estimate the fetal gestation age, and measurement of the knuckle translucency space at the back of the fetal neck. And the window of the testing using the combined test is about 11 plus 2 and 14 plus 1 days of the period pregnancy, and the window for testing the quadruple test is 14 plus 2 to 20 weeks, and the mid trimester anomaly scan between the 18 weeks to 20 weeks plus 6 gestation. Next question, in both parents they have the beta thalassemia minor, and what is the chances of the male offspring having the beta thalassemia minor? So this is again the repeated question. And as the there is as the beta thalassemia is not an X-linked condition, or so it does not depends on the genders. It will not create any difference in the genders, and any child will be having 1 in 4 chances of having the beta thalassemia major, and which is about 25%. So next question, what is the inheritance of the HNPCC, which is a Line syndrome? It is the autosomal dominant, and hereditary non-pole possess colorectal cancer. They are autosomal inheritance, and the increased risk of the colon, gastric, and the endometrial cancer, and 75%, 78% lifetime risk of the colorectal cancer, and 43% lifetime risk of the endometrial cancer. Next question, a woman they has undergo the genetic testing due to her family history and has a BRCA2 gene. What will be advised her the lifetime risk of the breast cancer? For the BRCA2 gene, it is we have discussed that for the BRCA2 genes, she has a lifetime risk of developing breast cancer is about 45%. Next question, a 15-year-old female investigated for primary amenorrhea. Ultrasonography shows no uterus. Mullerian agenesis is suspected. What is the karyotype in the Mullerian agenesis? In the Mullerian agenesis, so there are the two conditions with the congenital absence of the uterus. One is the Mullerian agenesis, which is also known as the Rokitansky-Klehor-Hauser syndrome, RKHS, and the other is the CAIS, which is also known as the testicular feminization syndrome. And among these two, that the Mullerian agenesis is more common because it occurs in 1 in 5,000 live births, compared to the CIS, which is 1 in 40,000 live births. So CIS will have the low E2 typically, and genetically the karyotype 46XY. Mullerian agenesis patients are the 46XX. So 46XX will be the answer. Okay, so next question. All of the following are the autosomal dominant except which one? So all of the following. So retinoblastoma, yes, it is autosomal dominant. Huntington is again autosomal dominant. Polycystic kidney is again autosomal dominant. Rett syndrome is an X-linked disease. Nonan is again the autosomal dominant. Here the polycystic kidney, they can be autosomal dominant as well as the autosomal recessive, and the most common is the adult polycystic kidney disease, which is autosomal dominant. So what percentage of the Turner syndrome, the conception, they will lead to the miscarriage? So it is more than 95% is the answer. Let's move to the next question. A 33-year-old woman, they has a blood taken at 13 weeks of gestation, which shows a reduced AFP, reduced HCG, and reduced estradiol. All three are the reduced. So what is the answer? Answer is the Alport syndrome. Alport syndrome, and it's clear from the investigations that whenever there is a raised AFP, you have to think about the neural tube defects in the or the multiple pregnancy. And when there is the low HCG, always think of the adverse syndrome. So which of the following statement regarding the BRCA gene mutation is true? So they account for around 25% of the inherited breast cancer. It is true. And around 1 in 20% or 1 in 20 or 5% of the people they diagnosed with the breast cancer will have the BRCA1 and the BRCA2 mutations, and they accounts for the 25% of the inheritance of the breast cancers. And men with BRCA mutations, they are at an increased risk with the lifetime risk of the breast cancer of about 1 to 7%. Next question. The NHC model of the best practice currently recommend the using the combined test for the screening of the chromosomal abnormalities such as the Down. Which serum markers they are measured when undertaking the combined test? So the answer it is the HCG and the PAP, because they are the number of the serum markers that can be used in a Down syndrome. Some of them are the triple test, quadruple test, and the combined test. And the combined test involves a single appointment where the rest of the serum markers, they are taken in the additional to the ultrasonography. And ultrasound they measures fetal length and the CRL to estimate the fetal gestation, and measurement of the nasal transparency space of the back of the fetal neck. And the window for the testing, the using the combined test is 11 weeks plus 2 to 14 plus 1 days of the pregnancy. So here this concludes are the sessions of the genetics SBS, and hope I made easy for you. And I'm going to upload the next video soon, so stay tuned, take care.